So these are the long-term results with custom-linked iodine 125 seeds and real-time brachytherapy for low and intermediate risk prostate cancer. This is a study that we have prepared. We are treating with seeds more than 19 years. So we have collected a prospective cohort of 706 patients, 480 low and 226 intermediate risk from October 2007 and until 2016. We have excluded some cases by different reasons, and the mean follow-up is the 96 months. In all cases treated with real-time calculation, this custom link iodine sits with the quick link system by BARBD, and this is published. This is a free access paper you can find in the Journal of Contemporary Brachytherapy. Down you can see. So the mean age was 66, between 44 and 81 years old, and all cases were treated with 145 grade in low risk cases, and in some cases of intermediate, we did at that moment a combined treatment, and we not all were treated in that way. 20% of all these cases were treated with a combined external radiation plus implant seeds treatment. The ADT was done around in 20% of those cases, but half of them were only because the prostate was big, so we needed to decrease the size in order to avoid this problem with the pubic arc, to be sure that we can cover properly the prostate. In general, the size you can see down is around 30 cc's before the implant, and the number of seeds around 57. With all that, these are the results. So in the total group, we have at 5 years very good results, 95%, even for intermediate risk. You can see there's a significant difference, but not very big. But we must see the results at 10 years, because like I like to say always, like in breast and prostate cancers must be studied at 10 years follow-up, because we need to know what will happen, because the recurrences can happen years after the treatment. So we have 92% at 10 years in low risk and 88% in intermediate. But we have talked that there is a difference, and you can see in our experience when we separated unfavorable intermediate risk, the results were worse. So we have learned two things: that the intermediate favorable cases can be treated with seeds alone, with the same results as in low risk, and that in unfavorable risk, we need to do something more, because only seeds that maybe are not enough. Maybe at 5 years is good enough, but at 10 years you can see that recurrences happen. And well, some people, some fellows tell, well, you are treating very low risk. Yeah, this is right. So we have separated these cases, and when we take out this very low risk that can be treated, well, can be managed only with active surveillance, in the low risk cases, we have the same very good results. So that means that seeds are working in all situations. When we decide if we use or not external radiation in low risk, of course we do not use, by different reasons in a few cases, but in intermediate risk, we have seen that it's not really a very big difference. Maybe a trend in combined treatment in unfavorable, but it's not really evident. So only looking at external radiation is not enough. If we look at the hormonal treatment, the ADT, we can see that in low risk it's not really necessary. Only these cases have been treated due to the size of the prostate to decrease the size. But an intermediate favorable, maybe in some case can be better, not in intermediate. So again, well, no differences when we use hormonal treatment or not in these cases, when we are giving very, very high doses with the seeds. So what we have seen is what happens with the other risk factor is the T stage, no? And we have seen that there is a clear difference between T1 and T2. And again, T2, there is no difference between T1, T2, T1A, T1B, or T1C. What does it mean? That when the tumor can be seen in the MRI or can be in the digital rectal examination, that is not always reliable, you know. In this study, only half patients had an MRI done at that moment, maybe 10, 15 years ago. So at the end, what we see is a difference. When the tumor is really present, the results are not as good as in cases than when the tumor is not really seen. And again, the other factor is the PSA. What happens, we have treated under 20. What if we compare patients with PSA under 10, low risk, are intermediate 10 to 20, we see that there is not really difference. But of course, the cases treated with PSA between 10 and 12, 10 and 20 are really relatively low. Only the median PSA in this group was 12. That means that, well, we have really, PSA is not the main factor in these cases. Of course, we are treating relatively low risk cases regarding PSA, but maybe the level of the PSA is not 10, should be maybe 15. The difference, well, this is in discussion nowadays. And what about Gleason? Well, and we see again, you remember the figure I showed you with the unfavorable risk is just the same. So we can realize that this Gleason is really one of the main factors, because when we have 4 plus 3, it's always worse. And again, when we are treating 3 plus 4, it's exactly the same as 3 plus 3. So again, this line separating intermediate, favorable, and unfavorable has happened in this study that we have done. And again, we can see, well, what happened if we use hormonal treatment with Gleason 4 plus 3, and you can see the big difference between them. And if we use external radiation, a combined treatment, again, is far better. So we have found one of the main reasons to have bad results in Gleason 4 plus 3 that have treated with a single treatment with SIDS. In these cases, we need a triple treatment with a combined treatment with ADT, 6 months, sterile radiation, and brachytherapy. And another factor that was forgotten in the past at the beginning, we did not see that, and we have reviewed what happened when we have more than 50% of positive cores. And we have seen exactly the same curve you can see on the left. And it's very interesting that you see that the curve decreases in the first 4 years. What does it mean? We are treating high-risk cases, even if in our classification they are intermediate or even low, because we have asked what happens if we have more than 50% cores and we have low risk according to the old classification. Well, in these low-risk cases, when we have less than 50% of positive cores, you can see again the same curve that shows that it's not working as good as we expected. Again, only this factor, even in theoretically low-risk cases, should be treated with a triple treatment with the same procedure. Well, another factor is important, age. What happened? Maybe in younger patients, things are not so good, and when we wait 10 years, maybe we'll have more recurrences, and it's just the opposite. Patients aged 60 or younger have better PSA control than older patients. So that was a surprise for us, no? Because we thought that in older men, probably the results at long term could be better, but it's just the opposite. That means that SIDS work a lot. Well, maybe we are selecting good cases. Not exactly, because you can see that we have really a small number of favorable or unfavorable intermediate cases. But again, on the right, you can see that there is a very good result in young men. Only 3 failures out of 150 cases, no? So there is a tendency to recommend surgery in these young patients at the moment. But with these radioactive seeds results, we can see that brachytherapy is clearly recommended. And of course, the erectile preservation is far better with brachytherapy against surgery. So this is another nice message. And again, quality. I've talked a lot about quality of the implant, and with this system, we can have in the green columns, you can see the prescription. No, we want to arrive to a V100 over 90 or 95. We give 108 in a combined treatment, or 145 gray in an exclusive seed treatments. Well, on the right in the orange columns, you can see the reality, what we are achieving with the ultrasound in the theater. These are the results. We are giving very high level of quality, very good dosimetries to these cases. And what is the result of that? That the nadir of PSA that I've told you before, that is considered nowadays under 0.2 as a biochemical definition of cure, as published by Dr. Crook, well, is what we have. We have analyzed 450 cases with PSA figures available after 5 years, because with shorter follow-up or recurrences we have avoided. And we have achieved a median PSA of 0.1. And we have reviewed all cases with PSA under 0.2. And of all those cases, we have seen only one case of long-term recurrence. So I think this is a very nice and good message again, to show what we are achieving. Well, what about complications? Well, we have urinary and rectal complications, of course, but as you can see down, the G3 complications are around 5.8 for urinary, for the urethra and bladder, and only 0.1 for rectum. Well, this is not the situation in the standard, that they have very high level of rectal toxicity, but the system of seeds was different. The dose given to the prostate was a bit higher than which we give with 108 in a combined treatment. And again, if we look at that, you can see the difference between the brachy alone on the left and the combined treatment. And again, with combined treatment, we have more level of complication as expected, but always in a low rate. 9% of stenosis, 5 that require some kind of TURP in 3.5% of the whole 700 cases we have treated. Incontinence in small cases, but a long term that due to the age can be seen, but really very low grade. And again, hematuria in a very low number of cases. So it's good accepted. This is the reason, because we give to the urethra a larger margin now, the diameter, trying to decrease these complications. We have not changing anything with rectum, because the incidence of rectal rates is really very low. It's only one case of G3 rectal raise that required treatment. So at the end, we think that is a very safe treatment. So only to show, not in low risk, that everything works in low risk, but I've shown you before in intermediate risk that maybe the discussion is not so clear. You can see in green the seeds results at 5 and 10 years in very well-known series, and Seattle, Monsignei, Anderson, Canada. So we can see that at 10 years and 5 years, when we compare with in blue the results of IMT, the results are better with seeds. Not always, you can see our results in Ivo Valencia, but when you look at the comparison with external radiation, we see that in this study of Italy, 11 institutions, that means that they are using different techniques of seeds, different experience in every case. So the results are similar to external radiation. But when we use good quality seeds brachytherapy and sometimes combined with external radiation for intermediate, we can get around 10% better long-term results than with external radiation alone. So this is a message again. So our conclusion is that prostate brachytherapy with seeds is a very effective long-term treatment, even in young patients. So that should be recommended. 10-year PSA control is over 92% in low risk and 88% in intermediate, but with this difference, that favorable intermediate risk is absolutely the same with SIDS alone as low risk, but unfavorable intermediate risk we should combine, even with this ADT for 6 months as our recommendation. The real-time technique with custom link SIDS, in this case with this ProLink system, improves clearly the implant quality, and this good dosimetry improves the results of exclusive standard radiation plus IDT more than 10% at 10 years. The nadir of PSA at 5 years is 0.1, that is one of the best you can find, and toxicity is low, very low, even with exclusive brachytherapy. So we can say that SIDS work. Thank you very much.